Kirby, are you still seeing the screen in slideshare mode or in display mode yet?
It's in slideshow, not quite in display yet.
Okay. I need to share another screen then. Okay, Kirby, what about now?
Perfect, it's in display mode.
Okay, all right.
It just switched back here. There we go, there we go. Yep, you're good.
All right, thanks everybody. Sorry for the internal technical difficulties there, but good afternoon and welcome to today's webinar hosted by the Georgia chapter of HFMA. I'm Laurie Heavey. I'm a Georgia HFMA Education Committee volunteer. This marks the end of our weekly webinar series that we started in April. For those of you who have been on with us, maybe from the beginning or periodically, I hope you've taken advantage of all the great content. Next month, we'll resume our previous schedule of 2 webinars per month. And please stay on the line after today's presentation. I'll give you some quick details about the 2 sessions we already have scheduled for June. And there are more virtual activities to come. We've had some virtual networking, both at the chapter and the region level. So please be on the lookout for regular emails from HFMA and check the events calendar online for a complete schedule of all of the activities. As we honored our U.S. military on Monday, it seemed only fitting that this week's webinar focus on Veterans Affairs, and we'll get to that in just a second. So before we get started, let me just review a few quick housekeeping items. All of the phone lines are on mute to avoid interruptions. Be sure to submit your questions via the question box at any time, and I'll coordinate with Kirby for his answers at the end of the presentation. You'll find a link to the presentation in the chat box once I'm able to get that set up. And this is going to be a link that will take you to the Georgia HFMA website, and you'll be able to find the presentation loaded under the tab entitled "In Case You Missed It." We'll also post the recording of today's session in that location, and you can find it on the Georgia HFMA YouTube channel. Everyone on today's call is eligible to receive continuing education credits. Be on the lookout for this form in your email. I'll be sending it to you. And again, my name is Laurie Heavey, so be on the lookout for an email from me. You'll be able to use this form to self-submit for your credit on the HFMA website under the membership tab, info tab. Now it's my pleasure to introduce our speaker, Kirby Yawn, who's Senior Vice President of Argos Health. Kirby is a Georgia native and an entrepreneur with several successful businesses under his belt. Argos Health is his latest venture. It was formed in 2017 to focus on healthcare business and resolving complex claims, including VA claims. In his role as Senior Vice President, Kirby helps to lead the company's solution strategy, focusing on healthcare client relationships and business development. Kirby, we're ready to begin.
Awesome. Thanks, Laurie. And everyone, I'll go ahead and warn you, we had to punt real quick where I'm talking through the cell phone and Laurie's running the slide deck. So unfortunately, this is going to be one of those presentations where you're going to hear me say, okay, Laurie, next slide, please, quite often. Considering we went through a practice run yesterday and it worked fine, and today we're having difficulty, my only hope and guess is it has something to do with the fact that space shuttle launch, or rocket launch, excuse me, is going to go off successfully in about 3.5 hours. So maybe we're just having a little technical difficulties because most of the bandwidth is being focused towards Florida this afternoon. And with that, Laurie, we're going to talk about Veterans Affairs claims today. I hope we present some items that make you think, wow, I really want to ask a question, or I need to know more about that. As Laurie said, please feel free to use the Q&A function of Zoom, because we'd love to have a little bit of a dialogue, or as much of a dialogue as we could have at the end, instead of this just being a monologue. Laurie rolled it to this next slide deck. And when I was over in Columbus in March, we talked about VA claims, and I told the crowd there that back sometime probably around 2010 or 2011 was the first time that I ever gave a presentation to an HFMA crowd. And I love the Far Side, love Gary Larson. I found this old Far Side sketch or comic. And it's funny, ever since then, it's never left the presentation that I've done, because I kind of feel like in the world we live in healthcare, we're definitely getting poked in the back, and we've got 2 doors that we're going to go in. hopefully most of the time they work out to the good. Lori, let's scroll to the next one. To get started, I just want to give you a little bit of a background on Argos Health. I know a lot of folks on the webinar, if you're from the Georgia chapter, you probably know me. You might even know the 4 services we provide. The services focus simply on complex claims. You see those listed out before you. Those are what we consider complex claims. Obviously, there's some hard claims in the healthcare space, and the more we go, you might think, well, every single claim gets harder and harder to get paid. We try to put the idea of complex claims into this one box, and we think those are work comp, VA claims, motor vehicle accident, which are also called third-party liability sometimes, and then your out-of-state Medicaid claims. So that's our sole focus, those 4 complex claims types. Laurie, let's move ahead. Last year, we were fortunate to be ranked #1 by the Black Book ranking. And so that was totally unbeknownst to us. I'm not sure if any of you have any knowledge of Black Book, but it's not one of those things where you get told something's being done. It just kind of, we got an email one day that we've been ranked #1. We were happy with the #1 ranking. What we were most proud of was that in 9 of the 18 categories, we actually ranked #1. So in half of them, we received the #1 ranking. So we thought that was a very good feather in our hat. And we've got one more slide. Laura, let's scroll to it. Just a quick fact about who we are. Obviously, we're a complex claim company. We've collected a little over $1.75 billion for our clients now. We've got over 200 hospitals under the belt with, now it's probably more at about 170-ish FTEs working for us. And you can see on the map, we've got 3 offices that operate, or where we operate our services out of. I'm sitting in the office in Augusta, Georgia, where we focus on the third-party liability and VA claims. Hudson, Ohio is the center for work comp claims. And then our out-of-state Medicaid office actually operates out of Phoenix, Arizona. And you see a little corporate headquarters there in Dallas. Now, before the next slide, which really starts to dive us into VA claims, we do want to state again that this is a very small portion of the revenue cycle, somewhere around that 5% mark, probably a little bit more than that when you start talking about all of the service lines. But it's amazing that such a small percentage of your claims can account for such a large headache. And those are the ones we like to focus on. So without further ado, let's jump into VA claims. Whoops. So just a question for the crowd, and I'd absolutely love it if everybody used the Q&A section just to go ahead and answer that question. Now, I think there's only 2 answers, yes or no, but certainly would not be surprised if someone were to throw in an answer to this question of, I think so, or maybe, or sometimes it seems like it, and sometimes it doesn't. The question, would you call the VA, the Veterans Affairs, would you call that health insurance in your normal definition of what health insurance should be? Let's give it like 10 seconds. I think, Laurie, I saw we might have 3. There's 4 responses. Yep. Let's just see if we get a 5. We'll give it maybe 5 to 10 more seconds. Maybe if some folks throw in a few more answers. I don't think, we're up to 11. That's good. Getting some response. All right, done. The drum roll, please. Let's go ahead and flip to that next screen. And the answer is no, you shouldn't. Now, obviously, that's a pretty blunt answer. So what we're going to do over the course of the next few minutes that we have together is we're going to discuss why in the world wouldn't you call the VA health insurance. Lori, let's slide to the next one. So you get into what are the major differences that you have between the VA and the other payers that you have in your rev cycle? Well, I mean, first and foremost, you have to ask yourself, do you have a contract with the VA? And then if you're going to answer that question, you have to then ask yourself, well, do you have a contract with TriWest? And now do you have one with Optum? Have you contacted United Healthcare to start the process of the contract with Optum? What's interesting, and we're going to discuss the Mission Act in just a little bit, is that up until the Mission Act went into effect, and then you have a TriWest takeover and then an Optum kind of on subcontracting. There weren't really defined what I would call contracts that you needed to sign. The last question in that first bullet point is, have you contacted United Healthcare to start the process? That is specifically in order to contract with Optum for the community network. If you haven't done that, and if that is not complete, let me just go ahead and say, maybe the number one takeaway you should take from this entire webinar is call United Healthcare / Optum today and get that started. Hopefully it's complete, because we're going to see some dates in a few slides where the rollout has already either happened or is quickly happening, and you would like to be contractually in that bucket. And we'll discuss a couple of reasons why that may make sense now, given the Mission Act environment that we're in. So we're back to answering the question, what are the major differences with the VA and other payers? The second one, do you know of any timely payment penalties with the VA? If you do, email me after this webinar and show me where you got that information. Because unlike, let's say, a Blue Cross Blue Shield or a UHC or an Aetna, where after claim submission and acceptance, if you aren't paid in a certain amount of time, you can enforce some timely payment penalties. That does not exist with the VA. I would guess a lot of the providers on the webinar are rolling their eyes and saying, you're absolutely right, it doesn't exist, because my claims take forever to pay. A third difference between the VA and the other payers, and this one, the gap is slowly narrowing, but you used to ask the question, could you name the VA policy number? Could you name the group number at time of registration? You absolutely used to not be able to do that. Now I've thrown a graphic in here, this card graphic that's taken directly from the va.gov website. And what you should start to see as you treat veterans is they should be able to present you with this Veterans Health Identification card. And in there, on the sample that you have, you can see that, lo and behold, there is all of a sudden a member ID number. There is a policy number. You do have the veteran's name and hopefully a picture associated with it. Now, the VA had to back up a few steps and take the same sort of path that Medicare did, in that they stopped using SSNs for identification. And I'm sure everyone in the provider realm that's on the webinar knows that it went from the Social Security being the way you identified a Medicare recipient to all of a sudden having a policy number, let's say. The VA followed that same suit. So you should start to see that, particularly if you're operating within the community care network. Now, the last bullet point with the VA claims, do you have any sort of data that you have loaded to your contract matrix? Do you have anything in your charge master? Do you have clearinghouse? Do you have those same sort of setups so that you know, well, when I submit a VA claim for X procedures, I should get paid Y? My guess is you do not have something that is exactly VA specific, but I'll ask a question. And again, let's use the Q&A section of Zoom to get a little interaction, virtual interaction going. If you had to pick a payer that you would mimic VA reimbursements after, who would that payer be? And we should slowly start to see a few little indicators that we're getting some answers thrown into that area. So again, the question is, if you had to mimic VA reimbursements after a particular payer, who would that payer be? So I can't see the Q&A answers right now, and that doesn't bother me, but hopefully you put in there Medicare, because the VA should pay at Medicare rates or at a percentile of Medicare rates if it's unauthorized care. But if you just needed to load something into your charge master, contract matrix, your reimbursement calculator, et cetera, picking Medicare would be a good way to go. It will not be absolute, but it'll be close that you could sit there and say, in a given calendar year, I know I have X number of VA claims worth X amount in charges, and I should get paid Y. And you can see how close you get to that. So another little tip to take away is maybe you don't already have that loaded as a reimbursement source into any of the modeling that you do. You could now if you just based it off of Medicare. Laura, let's roll to the next one. All right, so you got to ask yourself if it's not health insurance, because remember we asked the question earlier and we said, no, you shouldn't call it health insurance. Well, what exactly is it? And I don't need to read this quote that's there before you while I'm talking. Everyone on the webinar can read it, but this is directly from a handout from the VA, from a lunch and learn, I'll call it, we hosted back in around the 2015-ish timeframe. So you can see from this, the VA is not calling itself health insurance. They're saying that they just purchase care in the community for the providers that treat veterans. Now, one little interesting part about this, and I don't know if you've ever researched it before, but particularly in Georgia, around almost all of our cities, they do have these little things called CBOCs, which are the outpatient clinics. If you don't know if your community has one close by, and if you're not friends with those folks, I would encourage you to look it up. Again, from the va.gov website, you can go in there and search for community-based outpatient clinics, and you can figure out where your closest CBOC is. Oftentimes, it takes a little bit of education, not only for us as providers of healthcare, but also for the actual veterans, to let them know that there are places within our community where they can go and seek the outpatient care that they're looking for, that they're currently getting with you, particularly if they're coming to you for, let's just summarize it as minor ER reasons. A lot of times the veteran doesn't know, let's say in Albany, that there is an Albany VA clinic where they could go for what would be maybe the common cold or the fever, where they could get a checkup and then maybe a prescription prescribed, and they wouldn't have to come to your ER. So if you don't know where those are, I encourage you to go to the va.gov website and find those in your community, and then maybe start to educate a little bit in your community setting. So that's the VA's truest definition of what they call themselves, since we can't call them health insurance. And Lori, we can slide. So one thing I thought that might be helpful when we're talking about VA claims is to discuss some of the common terms that you hear. These are specific to the VA, and if you have some of your business office team members working VA claims, they might not have ever known the background of some of these terms, and they may not ever know if they are or when they are supposed to or supposed to not pay. The first one that you hear a lot in the VA space is the Millennium Act. So I've typed out the definition there, but basically the Millennium Act is a way that the VA said, okay, we know we're going to have emergency treatment in a community setting, and that veteran is not going to be able to go to a true blue, and I'm using air quotes, VA facility. So the Millennium Act was passed, and it said there are times where a veteran is not going to the ER because it's anything service related, and we're going to say that after review, we may actually pay that claim. Now, they certainly may not, but the Millennium Act said that they will consider it. There's a little bit of a more layman's term that you hear a lot in the VA space when they're referencing the Millennium Act, and that is mill bill ruling. And mill bill ruling just basically means we're going to run this through the Millennium Act scrubber and see if it pays. Now, the little dash mark below the definition of the Millennium Act is something we'll expand on in a second, but it's extremely important because the VA is going to consider that emergent treatment, but it's going to have a certain set of criteria that are met in order to even get far enough where they actually may pay. The first one, that notification within 72 hours, is extremely important. Again, we're going to talk about that later. You're going to need to have transmitted that claim electronically. You're going to need to follow it up with a paper claim, and you're going to need to follow it up with MedRecs. And those are all check marks that just lets the VA say, okay, has the provider done X, Y, and Z? Then yes, we will pay. Now, they certainly might also say, no, we will not pay, and there are many reasons why they wouldn't say that. But the Millennium Act is a pretty big term out there in VA claim space. Laurie, let's roll it to the next slide. So the next important definition, unauthorized claims. So a little bit different than Millennium Act, not too terribly much, but certainly something you hear when you're on the phone checking for claim status. Down in the middle of the paragraph about unauthorized claims is the most interesting statement I've ever seen with regards to a payer source, and that the unauthorized claims procedure allows for, and I'm skipping ahead, a person other than the veteran who paid for the services from the personal funds to present a claim for payment of a non-VA medical service that was not authorized in advance. So interestingly, a veteran could come in and their best friend could pay for the service that was not authorized, and the VA has said that we will pay that person back if they've done it. Now, you would think most of the time that relates to some sort of family member, but I don't know if I've ever noticed in some other language where it says they'll actually pay another person back like that. So unauthorized claim allows for things that are service-connected reasons, but didn't necessarily get authorization to have that treatment before they went in. And also they could not get to a federal facility in order to have that care. Now, so the difference between Millennium Act and unauthorized claims is basically whether it's service related or not. So on the unauthorized claims, you would imagine the patient has come to the ER and then they have some sort of further treatment. And that is for something that is known in the VA system, that the reason the patient is there is because they actually had this because of the service they provided to our country. So that's when you get into the unauthorized claim space. What's very important is the last bullet point is there is a strong chance you're only going to receive a partial payment on unauthorized claims. And that is to the point of stabilization, because the VA feels that if, let's just say, the visit needs to go ER to inpatient, by the time that decision is made, you should have contacted the VA and sought authorization for the inpatient care you are about to provide. So, that's a very critical point in making sure the claim gets paid to its fullest, and something that I would encourage you to have conversations with your patient admissions team about. Some of you on the webinar may actually handle both business office and admissions, so it's something to check up on. But that's one of the reasons why when you maybe get a partial payment back, that's something to look for. Is you should look and see, did we have an ER claim that resulted in further treatment and we did not seek the auth route somewhere in between. Laurie, let's slide to the next one. All right, so I talked about this a little bit a few slides back, but as most of you probably know, because it has made headlines before June 6, 2019, and certainly has made headlines after June 6, the Mission Act was a really big deal last summer. In fact, we're coming up on the 1-year anniversary of it. The idea behind the Mission Act was it would allow a veteran to seek or to have greater access to health care. And by doing that, they would be able to seek care within the community. So they wouldn't be required to have that care in a VA facility. So when June 6th came around, the VCP program completely went away, and the CCN program came into full effect. Now, obviously, when you talk about healthcare, and particularly when we talk about governmental healthcare, you get to a lot of acronyms, but now we refer to that as the CCN, the Community Care Network. And that was what was established when on June 6th, we said, okay, go forth and prosper with the Mission Act. When June 6th happened, it made a little bit of a shift in the payer space. It used to be that Tri-West was a TPA, I'll call them, that had the left half of the country, and a company called HealthNet had the right half of the country. Now, since we're on a Georgia HFMA webinar, and I would assume most folks are from either Georgia or Region 5, there may be some folks outside of that, which is fine, but a lot of us knew HealthNet leading up to the Mission Act. And then all of a sudden it was announced, well, Tri-West is going to be the TPA for this community care for the entire country. Well, I think shortly after that, Tri-West might have figured out this is a humongous thing we've taken on. And so you started to hear the rumblings of they're going to outsource some of this work. And that is why you now have Optum involved. And the last bullet point I there's going to be some region talk on this discussion, so I want to make sure we're defining which region we're talking about. But as it stands for HFMA Region 5, we're basically what I would call Optum folks. So in the community care network established by the Mission Act, our claims should be going to Optum for treatment other than those at a VA facility. In the VA terminology, our whole area is Region 3, and there's a couple of cities that are actually in Region 2. I'm not sure how that worked up. But let's slide to the next one, and I'll show you what I mean. So these are the Optum go live dates, and as you'll see, a lot of these are in the past. Well, excuse me, some of these are in the past, and some of them are coming very quickly. This has been updated. We're probably on the third, maybe fourth schedule now for when some of these cities will convert to Optum. But I had to throw the left side in there because even though you see some Oklahomas and Missouris, those couple of Tennessees make up part of our Region 5. And so those areas should already be on Optum. And then if you look at the right-hand chart that I copied and pasted in there, that's when the full go live happens for Optum. Now, if you'll remember back to one of the first slides I had, I said, if you haven't contacted United Healthcare / Optum to go ahead and get signed up contractually, you should. As you can see, the deadline for that is coming very quickly. So hopefully everybody that's involved in the webinar has already at least started that happening. And you should be reaching some finality because some of these, as you can see, these cities, that it's actually happening here very quickly. So before we roll to the next slide, let me go ahead and stop here because I thought it would be a good time to just emphasize, don't forget the Q&A section, because there are some things around CCN, Optum, wait, what's TriWest? I thought we had Tricare, that sometimes spark some questions. And so I want to remind you that we've got that option there. As Laurie said, we're going to get to those at the end of the webinar. And if there's anything in there that catches me off guard, Laurie will know who submitted it, and I will gladly get you a specific answer immediately following the webinar. I should be able to ad-lib it pretty good based off of what the questions are. But everybody take note of this. Remember, you can get to the slide deck later. But again, if you haven't started those contract discussions with Optum / UHC, you need to ASAP. All right, so Laurie, let's slide ahead one. All right. I wanted to just try to crystal ball it a little bit on what exactly the Mission Act would mean for a provider. Ever since we started working VA claims about 8 years ago, whenever I talk about VA claims, there is the definite eye roll from the provider side. But I think we've got some good news coming from the Mission Act. The first bullet point to me is great news. There is a definite way for veterans to have services authorized. There's a definite way for you to be in a contract situation for reimbursement for that. There are guidelines for how those claims are submitted, how they're processed and paid. And I think we would all agree that when you have authorized care, it's better than obviously ER unauthorized care. So I think that the number of authorized claims that all facilities are going to see is going to go up. Now, a lot of the reason I think that is because some of the credentials, or excuse me, some of the requirements that you have to have in order to get that care approved became a little friendlier, let's say. You used to have to live a certain distance by mile from a VA facility in order to get some care authorized. Now you have to live a certain distance travel time. So as you can imagine, in some of our denser areas, I mean, let's say Atlanta, you could live 8 miles from the nearest VA facility, but your drive time could be 45 minutes. Well, because they shrunk the drive, they shrunk it to a drive time instead of drive distance, that might allow for a little bump up of authorized care in your provider setting in that city. So some things like that happen that I think will drive the authorized claims volume to go up, which should be good. The other thing that I thought was interesting about the Mission Act is it does have an urgent care component. So when I'm talking about urgent care, again, I'll use air quotes that no one can see. I'm thinking of the doc in a box setting. So the Mission Act said, hey, veterans, you can, some of this care that you've been going to a large facility for, particularly through maybe the ER, we're now going to approve you to have that done in an urgent care setting. And that was never available before. So if some of that ER traffic could be moved to the urgent care centers in your community, that would mean your ER volume goes down. Those are typically the hardest claims to get paid, which should be good so that you could spend more time focusing on your claims that pay higher, probably easier. So you might see your ER volume dip a little bit in the VA setting because they're accessing that urgent care component. Now, the third bullet point on here, my predictions for what happens with the Mission Act, it's a little outdated because now we're going to definitely see how it happens with TriWest and the subcontractors. If TriWest had remained the only TPA for the community care network, I think we would have had some serious hiccups because the volume was going to be so great. To give you an idea of that, a study back towards, I believe it was the end of the year, was done on how far behind the VA was on medical records uploading. I would think when in today's world, because we live in the digital age, we would have talked about, hey, the VA has X number of gigabytes to go to or current. They actually said the VA was 5.5 miles behind in uploading medical records, and that's standing the paper edge on edge, not laying it down flat. So you can imagine what 5.5 miles of paper stacked side by side looks like. And that's how far behind they were on medical records being uploaded in order for claims to process and pay. If TriWest had tried to take over something like that, just think how great that influx would have been at first. So now we definitely know that the TriWest implementation, someone else realized it was going to be rocky, and now we have Optum in there, which hopefully will alleviate some of the problems with what the CCN may bring, in that we have authorized care, we have a TPA, et cetera, et cetera, et cetera. So those were my predictions for the Mission Act. Some of these are slowly starting to come true. As you know from the previous slide, when I had those dates listed out, some of them we're still kind of waiting to see, well, what really is going to happen with authorized care as we move forward with the go live of Optum. And before we move off of this slide, I will say, if you listen to any of the Senate briefings that were made available online, you do know that the VA did admit the Mission Act didn't go off without a hitch. You would, if you listen to those, you would have heard that there was concern that some veterans still weren't getting some of the authorized care authorized in a short amount of time, which was part of the, that was one of the main reasons to go forward with the Mission Act. So it's still being felt out, but these were my predictions, and we'll still have to wait a little bit to see how it goes. Laurie, we can slip to the next one. So we've covered a lot, and you have to ask yourself, I still got VA claims, so what in the world am I going to do? Some of these slides have been on here in a couple of different presentation settings that I've been in, and they haven't changed a whole lot because we haven't gotten through the Mission Act. But I'm going to give you 3 tips that I think you could take away from the webinar. You could implement them tomorrow at your facility, and you could see better results in your VA claims. The first one is notification, notification, notification. And by that, I am definitely not talking about authorization. So the VA wants to be notified when you have a veteran there for service, particularly in an ER setting, but even in scheduled outpatient or scheduled inpatient settings as well. And that notification needs to take place within 72 hours. So the good news about that is your third shift ER team doesn't have to give notification at time of treatment because you've probably scaled that team back a little bit for volume. But someone needs to have some sort of cue that they can review the next day or the day after, so that they can go by and notify and meet this 72-hour time frame, especially in the ER setting, because that could be the number one factor as to what makes ER VA claims pay a little quicker than normal. The second good news that comes with notification is you don't even have to, or excuse me, there's a way where you don't have to overburden your weekend shifts, because the VA, you should be able to call and get the WIN number, the last little bullet point on there, weekend, holiday, evening, and night number, so that you can notify by utilizing a phone system tree. So I'd say it's better than it's ever been as far as how you can notify and not have to actually speak to a person at the VA. Is it great? No. But do you need to do it? Absolutely. Notification is of paramount importance. Laurie, let's skip to the next one. Second big takeaway that I would suggest is authorization, especially when we talk about the unauthorized claim setting where you are going ER to outpatient or ER to inpatient. You have got to seek that authorization for the shift between the two settings. Otherwise, you will seek a partially paid, or you will receive a partially paid claim, if not a completely denied claim. Every time you see a veteran that wants to have a treatment other than a VA facility or a CBOC, and it's not emergent in nature, you should have some sort of authorization on file. In the past, it's always come with a QR code toward the right side, and that QR code is basically what drives it through the entire VA system. Optum is probably going to have something that is very similar and may operate just like your normal UHC claims. But you can also get, and I have it in all caps with a bunch of exclamation points, you can also seek retro ER authorization for VA claims. We work for a very, very high volume health system in Ohio, and they have gotten extremely good at ER authorizations. They created it as part of an SOP. It got rolled out to their patient access team. It's now something they follow very, very closely. They were able to cut their VA payment timeframe in half. It has been an extremely successful effort on both the hospital and our part in order to get that set up and going. If you could leave your office right now and go talk to someone in patient access and say, hey, do we have something in place for ER authorizations for VA claims? And they say no, it could be a very, very, very beneficial priority that you put in place. And then the last one, I need to put Optum towards the end of the slide, but I don't know if it's a tip of the day anymore, because by now what we're finding is most providers have switched over to EDI transmission. If you have not, please, please, please do everything you can in order to make sure that you've got that set up for both traditional VA claims, for both TriWest and or Optum claims. Make sure you've got it in place for ChampVA, Tricare claims. If you need any help with that, I'm going to show my email address at the end of the slide. You probably predicted that would happen. If you just need to email me and say, hey, point me in the right direction where I even get that going for our IT team to get that implemented, please do so. I will gladly provide you with the tips that we provide to our hospitals when we're onboarding them for implementation to get the EDI transmission set up. While it is not a 100% proven fact, if VA claims don't go out electronic and paper, it is more than likely going to have the most difficult road to get paid. I can't say that electronic claims are 100% the answer, and I can't say that paper claims are 100% the answer. We're still in an environment where you're going to need to do both. But please make sure that's set up for all of your military payers. And Laurie, we can slip ahead to the next one. So last little kind of tip of the day that you could take back to your teams is I would advise you to put a concerted effort at registration for gathering, and I've called it primary payer information. So this is where it's very helpful for the business office to have told patient access some of the problems they're seeing. Candidly, a lot of your claims that come through the ER may not even be VA claims. However, at time of registration, admission, etc., you may just be told, well, I have VA coverage. I would advise running this by your compliance officer, or whomever needs to check off on it. But you want your patient access team to be in the habit of saying something along the lines of the script that I've added in the second bullet point. Now, I don't expect anybody to ever use my script verbatim because I haven't run it by a compliance officer, but somehow they need to say, if the VA does not pay this claim, are you sure you don't have an insurance you want me to have on filing, so it won't be your sole responsibility? So what you'll find is a lot of ER care is really not the responsibility of the VA. It's the other health insurance that should be paying for it. If you don't have that other health insurance on file, the last bullet point on here is make sure your business office team is just in the habit of looking back, maybe around the 3 to 4 month time frame within your EMR system to see, well, did this patient have a previous visit and was it paid by another payer? Could we check availability or the payer portal to see if that coverage is still active and viable? And if so, you might have a claim that needs to go to that other payer. However, all of that work on the back end, as I'm sure everybody that's on the webinar that's solely from the business office could attest to, is that work on the back end is more difficult, we would say, maybe, than gathering it at time of reg. So last tip of the day, just make sure that you've got your team set up to ask for that primary payer information. I have noticed that there's some questions coming in through the Q&A tool. I'm assuming those are questions. So again, don't be afraid to type something in there. Lori, let's scroll to the next one. So last few slides are going to focus on some kind of other payer information before we get to a case study. Typically, when we start bringing up things like the term Tri-West with regards to the community care network, et cetera, someone inevitably will raise their hand and say, well, what about Tricare? So Tricare is in its completely other bucket than Tri-West. In fact, Tricare you could put into the bucket of health insurance. Certainly, Tricare is available to active duty, and Tricare for Life, you may hear it referred to as, is available to retired service members and their families. So don't get Tri-West and Tricare, and especially Tricare West, confused. Tricare you could have, let's say, as its whole other financial class. That is technically not a VA claim. I would think you would have more of a health insurance claim on your hands when you get to Tricare. But you may get some questions from your business office team members about, well, we've got this Tri-West thing going and I'm doing, X, Y, and Z for Tricare. Why don't I do it for Tri-West? It's because Tricare is not the same thing. Talking about Tricare will sometimes spark some questions. So don't be afraid to type those in there. If you say, well, wait a second, I've got this whole other Tricare thing I'd like to have you talk about. I do have a fairly extensive, I'd say, knowledge of Tricare. There's a chance I may have to circle back to you, but please don't be afraid to ask. Lori, let's skip ahead. So what about ChampVA? ChampVA is basically what you could think of as coverage for the spouse and children. ChampVA, like Tricare, I would think of as its own quote unquote health insurance. So when you have ChampVA claims on your hands, you're talking about something that's completely different than the previous slides we've gone to talking about VA, Tri-West, and Optum. So ChampVA is an entire other insurance, and you could even think of it as an entire other financial class within your EMR/payment posting system. Might have some questions about ChampVA. Again, don't be afraid to ask. And Laurie, we can slide ahead and I'll move through these pretty quickly. So I did want to throw in a few case studies here, just some different ways to think about VA claims. Some might say they could be a little bit salesy, and I will admit they do have a little bit of a sales tone to them, but I want you to see some of the things that can happen if you really start to focus on your VA claims. We have a hospital, 83 beds, not really by some folks' standards, a big hospital. They have fair amount of claims, 91,000 a year, $8,400 average a claim. So pretty good volumes and claim amounts there. They only saw about 102 VA claims a year, but the problem was 26 were being self-pay and 20 were being completely written off. So even though they only had 102 claims a year, half of them were receiving basically a zero payment on. So what did they do? They outsourced. And by outsourcing, you could also say, what did they do? They focused on some of the things that I just talked about in the previous slides. Lori, let's flip ahead. So in the first year of being outsourced, those 102 claims, in the following year, only one ever went to self-pay and 0 were written off. But I want you to think about it in a different light. What they found was if we can just get these going correctly, we could probably focus some of that FTE's time on a different kind of claim. And for that particular hospital, Medicare is a big deal, 44% of their patient population. So they focused that VA or that former VA team member's time on Medicare claims. Their Medicare Advantage AR decreased 50%, and the number of Medicare accounts aged over 180 decreased 90%. So some of you on the webinar may say, well, I'm a pretty big Medicare facility too. Think what could happen if you could repatriate some of that employee's time to working your highest and better reimbursing payer. Pretty drastic results right there. One more quick little case study. Laura, you can flip ahead to the next slide. This was a 4-hospital health system. We started working February 2019. By February 2020, we collected $1.4 million more than the year before on their VA claims. Now, I would pat ourselves on the back and say that's the results of Argos Health. It's also the result of knowing what happens in a VA claim and some of the things that I mentioned before in the slide deck of some tips and things you can do at your facility in order to make those claims pay like they should. So pretty what I would consider incredible results like there in a year just to find an additional $1.4 million that could come in the door. And Laurie, we can skip ahead one more slide. I won't really even talk about these because it does get a little salesy and we've only got a little bit of time left. We've got some before and afters, and you'll see this if you want a copy of the deck later of kind of what was happening before we took over and now what's happening after. And Laurie, if you slip ahead one more slide, we can leave it right there on that last one. And you'll see my information and you'll also see Zach's information. If you're on here from Region 5, you probably know maybe both of us, but definitely probably Zach from being on the board of Georgia HFMA. So there's our contact information. With that, Laurie, do we have any questions we need to go over?
We do. We have a few here. First question, when you speak with the VA and ask about a reference number for the notification, they don't have a reference number. They say they will give you their name and date and time. It's not really that solid. So I don't know what the question is there, but I guess maybe comment.
Yeah, and did that question say that's really not that solid?
Yes.
Yeah.
I didn't know. That wasn't my commentary on the question.
I didn't think it was, but it's funny. We could almost use that phrase of that's really not that solid, and we could apply that to a lot of the things I just talked about within the program. There is a lot of unsolid ground within the VA. Normally when you call for notification, et cetera, you would think in our team here in Augusta for some of the other, in all of our offices for some of the other claims we work, they're in the habit of getting a call reference number, jotting it down, making sure it gets noted in our system, et cetera, et cetera, et cetera. Yeah, we're just not there yet, but I would think it's coming. And I would think it's coming even more so when you start to talk about things like Optum now being in the mix. And to me, Optum being in the mix from the payer side starts to bring in a little more maybe normalcy from the payer side that we're all used to. So I think you'll see some of that start to get better.
Okay, next question. ER claims are being denied by the VA after the 120-day TriWest timely filing limit. Most of the time, the VA has not completed these authorizations with TriWest, and we're getting timely filing denials from TriWest. What is our recourse for getting paid?
Yeah, so I will, there is some leniency that some notices came out and said, yes, they may receive denials, but they will go back for lack of a better term, while we're talking in retro, get those taken care of. Laurie, I'm assuming we know exactly who asked that question. And what I can do is I can feed out the answer to that, because our team is aware that those are kind of sitting in a holding pattern, so that we can circle back. My hunch is that maybe you've got those because some of this conversion time frame that happened, but those should get cleared up as we move through time. But Laurie, if you will, after this, just make sure I've got that so I can get them the definitive, not press release, but notification that the VA sent out about that.
Sure, we'll do. Okay. Next question. When will the VA be able to receive medical records electronically?
Don't know the answer to that. They haven't released that information. Now, we have had minor success with some facilities being able to set up a direct SFTP feed to their local VA to allow us to transmit those documents across the internet waves, or the SFTP waves, whatever you want to call it, so that we can do that. But that's been in some very specific one-to-one facility locations. It's not available yet on a broad basis. Now, I would think the further along we get with their conversion to Cerner, that big, I believe it ended up being a $16 billion deal that happened. We need that to happen in order for the whole thing to come full circle, like you would with your other payers, where you would be able to upload those electronically. But the go live for that, the very first Cerner got delayed 5-6 months, and then we had COVID hit. So everything, I'm assuming, has probably now been pushed even further than any of us would like. But if we can get to that $16 billion deal being done, we'll be really close to that transmission of records electronically. And that's, I don't know if anybody reads the headlines, but that's a concerted effort with the Department of Defense and the way that the VA works, et cetera. So it's kind of bringing all those systems together into one. And so we should see some pretty big leaps and bounds with that happening.
Okay. Next question. You indicated that veterans were receiving a policy number. When we've used this number on claims to the VA, I receive a letter from the VA Community Care saying they need the 9-digit Social Security number. So maybe you can comment on that.
Yeah, I think that's just where we're back to the not too solid comment, in that the whole reasoning going with the policy number is so that you didn't have to do that. But yeah, it's kind of like an electronic claim. In my statement of the electronic claim doesn't get it paid every single time, and the paper claim doesn't get it paid every single time. We've still got some lapses in the flow of communication between the payer sources. And so that's where you're running into those problems of policy numbers aren't lining up with SSNs. And so one or the other's having to still be asked for. It's still a little bit of a nightmare.
Okay. Next question. Do you have any tips on how to get past Health Net claims paid?
Ooh, Laurie, make sure I know who that is. I will get that person the exact date of when we've gone too far, and we are quickly approaching that. As you can imagine, Health Net probably wanted a pretty stringent into that too. If I tried to give a date right now off the top of my head, I will miss it. But our Autumn Schneider, who is the director of our VA team, she will know exactly when that cutoff date is.
Okay, so for the person who asked this question, it came in as an anonymous attendee. So if you wouldn't mind, please, you can either email me or Kirby with your question.
Yep.
If you'd like to do that.
Yeah, and we've got, I should be able to get Autumn to provide me with, again, a notice that they put out on when those timeframes were, because you had one date, which I believe it was March 1st, where the claim had to be in, and then there's going to be there's another date out there on when that claim decision could be denied, appealed, et cetera. And we're quickly getting there, but I don't remember when that date is off the top of my head.
Okay, we have 2 more questions and 2 more minutes. Does Atlanta allow the SFTP for medical records upload?
Not that I've heard. Where we were doing that was in Ohio, and it was a multi-year, many meeting process to get that done.
Okay. What can you do when VA claims denies as auth is through TriWest and you contact TriWest and they advise there is no auth, and you contact VA Community Care and they say they will not create a TriWest authorization?
I don't know that I've directly been involved with one of those. I'm trying to think. I'm going to have to punt to a specific, getting someone on our VA team to give me the answer to that.
Okay. This question also is from an anonymous attendee. So to the person who asked it, again, if you will email Kirby directly, and you can see his email address, kyawn@argoshealth.com. So those 2 people who came in as anonymous, if you wouldn't mind doing that directly, that'd be great.
Yep. And those are some of those that I'm going to rely on our specific VA team members to give me the answers to. Those are all good things that we can maybe have another webinar on that will follow up maybe after summer's passed and we're all back in our offices back to normal. And I'll make sure to get those answers out there, even in future presentations.
Okay. All right. Well, Kirby, thanks very much. This concludes our session for today. And please be sure to join us in 2 weeks on June 10th. That's when we'll have our next webinar, Digital Patient Engagement. It'll be featuring a case study of new patient engagement tactics at Jackson Hospital in Montgomery, Alabama. And then the next Wednesday, June 17th, we'll have noted speaker Jonathan Wick of TransUnion, who's going to be giving an update on revenue recovery tactics in our COVID-19 environment. So please do be on the lookout for regular emails from the Georgia HFMA for the latest on our Wednesday webinars and other activities. Thanks everybody for participating in today's webinar, and Kirby, thank you for sharing your expertise and being flexible with our technical difficulties. Glad it worked out. We will be posting Kirby's presentation and a recording of today's session by the end of the week. You'll find that on the Georgia HFMA website. And then again, just be on the lookout for an email from me, Laurie Hebe, with your CPE credit form, which you can self-submit. Thanks again, everybody, for joining us. Stay safe and have a great afternoon.